The Senior Rehab podcast is sponsored by Great Seminars and Books. If you need high-quality geriatric con ed that's worth your time and money, check out Great. Owned by the living legend Carol Lewis, Great offers courses and products created by recognized leaders in geriatrics. Learn the most effective techniques for diagnosing and treating your patients. Just go to seniorrehabproject.com/great and get $25 off by using the code SRP25. The show is also sponsored by you, the listener. Go to seniorrehabproject.com/join to find out how you can help steer the direction of this movement and join our monthly meetup. Once again, that is seniorrehabproject.com/join. Hit me.
Welcome to the Senior Rehab Podcast.
The podcast for rehab clinicians that want to better serve older adults.
And now, your host, Dustin Jones.
Hello, friends. Welcome to the Senior Rehab Podcast. Thank you for the download today. On the show, we have Kenneth Miller. He is an educator, researcher, and a physical therapist in practice for over 20 years. Dr. Miller is a board-certified geriatric specialist, credentialed clinical instructor, and a master trainer in team strategies and tools to enhance performance and patient safety. He serves as a contributing faculty member for the University of St. Augustine DPT program and is an adjunct professor in the DPT program at Touro College. Dr. Miller has presented at the CSM, at APTA's Next Conference, and at other national conferences. He currently serves as the chair of the practice committee of the home health section, whoop whoop, and is on the editorial board of topics in geriatric rehabilitation and a manuscript reviewer for the Journal of Geriatric Physical Therapy and the Journal of Primary Care. His areas of interest include care transitions, pharmacology, and patient engagement. And now he can add one more thing to his resume, the latest guest of the Senior Rehab Podcast. Ken, good morning.
Good morning. How are you?
Better than I deserve, I'll tell you. I was being sarcastic about that point about adding the Senior Rehab Podcast to your resume. That could come back to bite you, so you probably don't want to add that one.
Okay, sounds. I'll take that up under advisement.
All right. So I feel like we've been interacting a good bit online, especially on Twitter, over the past few months. And I finally got to meet you at CSM this past year in Texas. I'm curious, what's your take of CSM this past year? What were the big takeaway points for you?
I think the biggest takeaway was the fact that regardless of what section, what APTA component courses people went to, the topics that were most discussed were defining value, as well as using objective tests to define that value, and seeing where physical therapy fits as a whole in the changing healthcare system. And I think this is really the first CSM that I've gone to where it was so universal that regardless of what practice setting a person worked in, whether it was home health or outpatient, private practice, hospital-based, or inpatient even, everybody was really discussing value and saying, is what I'm doing effective? And is what I'm doing valuable to the patient? And I think that's a really important point considering what's happening in DC right now with repealing of the Obamacare and trying to replace that with some other plan that currently is in its current shape, or something that a lot of the American Medical Association and other associations are very set against because of how they feel that it will be reducing coverage and marginalizing coverage for our most vulnerable population. So I think that's the big thing of CSM advocacy.
Yeah, and that conversation, that was happening in a lot of educational sessions, but at the bars too. I remember having several conversations just casually outside of the sessions of how do we show our value, and prove that to the people that we're working with. So I guess from your perspective, how are we doing in the home health arena of demonstrating our value as it stands?
In my capacity with the home health section and privately in my daily work, my day-to-day life and consulting work I do, I think that overall the home health therapists are much better at using objective tests. We've been the practice setting that has had that mandate from CMS for the longest out of all physical therapy practice settings. So I think finally we've gotten to the point where we now realize as an industry, we need to be doing objective tests. Where we can improve on that is to take those objective tests and then actually create professional opinion statements and defining and interpreting the data so that any auditors or reviewers that look at the information that are not therapists understand what the data actually means. And so I think we're at the point where we're gathering data. I'm still very suspicious about the quality of the data gathered, and I have a couple of concerns with the APTA database that they want to have all this information uploaded, because I think dirty data can hurt us. And I'm not sure that having all this data up there that we don't know is accurate, clean, reliable, valid data is in the end going to help us. And so that's where I think we are currently doing the tests. We need to make sure that we have fidelity with the tests, that they're valid and reliable, and then properly interpreting the tests, and then creating outcomes that are measurable, that demonstrate true value to the patients and the clients that we're working with.
Dirty data. That's a good term. It makes me think of, certain situations where I've been, just practicing as a home health PT. It is interesting to see how, I guess, our documentation systems can really influence practice behavior. It's like, for me, for example, I can't submit certain documents without giving certain objective measures, which it is a constant reminder for me to do those objective measures. But then also, if I don't get around to that objective measure during the session or the evaluation or whatnot, it is very easy for me to make up a number to include it, or to use a previous numbers assessment. It kind of forces me to put something in there. And in some situations, you can't put anything in there. I could see how that could become an issue if that is a trend, and with other therapists and collecting that data. Have you worked much with documentation systems in collecting that data to actually use and interpret?
So that brings up a really good barrier or a challenge if we want to look at it from the positive side of things. We all have challenges using EMRs, and to answer your question specifically, I do modify our EMR that we use at our organization as much as I can to try to help the therapist document accurately. And some computer systems have hard stops and soft, and then there are also soft stops. A hard stop is what you're defining that, oh, shoot, it's asking for a measure that I didn't do, and it will not let me complete and validate this assessment and synchronize it over because I'm missing a piece of information that the computer is requiring me to complete. And so now what happens is clinicians that forgot to do that measure, or the patient wasn't appropriate for that day to do the measure, blood pressure was elevated or some other clinical reason, now we have an issue where the EMR is forcing me to put something in. And so for me to complete it, I now have to put in either a data that is inaccurate, made up data, or data that might possibly be old data that I'm going to now carry through into the current visit, which could be data from 2 weeks prior.
Right.
And so what we try to do in that situation for hard stops that we have is we have comment boxes and text boxes. And so anytime we have to put in a measure or something that is not accurate just to complete the assessment, we have the clinicians write a clinical note or write in the text box that the data in this certain field is not accurate, and that the data was only entered to complete the assessment, and that the assessment that tool may not have been completed because of, and then document that patient reason. EMRs are a challenge because a lot of systems are now in place to force therapists to do objective measures, and unfortunately, sometimes I look at EMRs and they force an objective measure for balance on every single patient. And not every patient has a balance impairment. And so if you make me do a balance measure on someone, then their balance is intact, but maybe they have an aerobic capacity challenge. Balance is intact. I just documented there's no skilled need for balance training. Well, maybe I didn't even need to do that test in the first place. And perhaps if I were able to select the measures that I need from the Guide for PT Practice categories, or the book that we have put out for the home health section, the Practicing Therapy in the Home, that has ideas of how to do testing.
Mm-hmm.
Maybe I can select what I feel, in my opinion, is really what's important for the patient. So I think test selection is a challenge with the EMRs forcing me to complete a Tonetti assessment or a Berg assessment when it's not appropriate for patients.
Could you talk more about that book that you just mentioned? I believe it's available to home health section members for free. Is that correct?
Yeah. So a couple of years ago, I think it's 2 years now, we finished the third edition of a handbook for home health. The title of the book was changed to Providing Physical Therapy in the Home. It is available as a hard copy book on the APTA store, but all home health section members have access to that book as a PDF. They could download for free as a part of the membership. And so I recommend to many clinicians to join the home health section, even if they join for 1 year and get that book. Mm-hmm. Buying that book from the APTA store is, I think, $65 or $50, something like that. It's cheaper to join the section and get a PDF of the book, as well as all of the other resources that we create. And the practice committee, of which I chair, we are always active creating resources to try to help improve practice and improve the patient care that we provide.
Yeah. Yeah, I'll put a link to that in the show notes. And I do encourage all the listeners. I mean, there's many listeners that have been in home health for a while. There's some that are thinking about making the jump. A lot of new clinicians as well. I mean, check this book out. I know I've got a copy of it, and it's been an awesome resource for me so far. So yeah, kudos to you for putting that together and kind of leading that team.
Thank you.
You've done all kinds of stuff. I mean, teaching, consulting, practicing. I've seen a few of your MedBridge courses, and you cover so many different topics. I mean, it's really impressive. We've already talked about kind of value-based care, but I do want to get your opinion on something else that I've seen you talk a lot about on the Twitter sphere, and that is our role in kind of population health. In health and wellness, and just how we should position ourselves to help people way beyond, kind of the current model that we serve in. You got your background in home health. How have you? What's your take of all this talk about the health promotion that we see online and even saw at CSM as well? I'd like to hear your opinion just from the home health perspective.
So. I've been involved in the home health section and in home health industry for over 20 years, but I also work for a hospital system. So being a part of a hospital system with 6 hospitals, 3 nursing homes, including outpatient network throughout our region, I'm involved in different level meetings at system level, our organization, interorganizational level. So I have a vast a broad view of therapy across the whole spectrum, including from pediatrics all the way through geriatrics, which is my specialty. Mm. And so with going to the meetings and research that I've seen from Jason Falvey and others, seeing that physical disability, physical impairment, frailty, these are factors that are major factors involved in preventing chronic disease. And so it really pushed me down a rabbit hole that I have been able to climb out of, but it pushed me down made me go down a rabbit hole to say, well, what can we do for diabetes? What can we do for these other health conditions, COPD and osteoporosis and heart failure? And, we're asked now in home health, especially, keep them out of the hospital 30 days, keep them out of the hospital 30 days. So, my vision for home therapists is we are public health therapists. Mm. It's very different mindset for therapists in home care that we're dealing with the medical model of disease so much more so than if it were a private practice treating orthopedic patients or even other diseases, other diagnoses. In the home, it's such an interdisciplinary model of care where the focus is so much more of a medical assessment on the patients and pushing them as much as we are able to safely, functionally, and physically, I saw that physical therapy has such an opportunity to partner with accountable care organizations and other new models of care, including the bundling arrangements, to show that physical activity and lack of physical activity is one of the major determinants of future frailty and future decline and future chronic disease problems. And so I did a lot of research on diabetes and looking at what happens when someone is pre-diabetic and if they get on a program of exercise. And this research is not new research. It's been around since 2002. And there's research showing that if you lose 7% of your body weight, that's what the goal of the initial program was, if I'm remembering that correctly. But if they were to lose weight, they were to do some specific aerobic exercise and resistive exercise, follow a tailored diet for weight loss. The goal of that initial program was not to control blood sugar, but for weight loss. These people showed a decrease in moving toward full-blown diabetes type 2. And in fact, other research shows that when you do an aerobic exercise component at the correct intensity, you actually improve insulin sensitivity. And when you do a resistive training program to help these muscles function more effectively, then you're burning that glucose more effectively, and you've improved insulin sensitivity and you reduced insulin resistance. And so I said, wow, there's so much that we can do. And I've been told time and again in my meetings around the country even, therapists don't treat diabetes. And I argue we do treat diabetes because there's a tripod to treat diabetes. And the tripod is your diet. It's also your physical activity. And then lastly, it's your medications. And medication should be the last line, not the first line to control diabetes. It should be get on the right diet to lose weight if you are overweight and have obesity, so get on the correct diet and exercise. And yet patients are referred from their primaries for, they get nutrition counseling, maybe a dietitian visit, maybe they see a diabetic educator. And I think these are all necessary. But on the therapy end, on the physical activity end, it's, go do some walking. You need to be more active. And without any kind of a structure or guidance, patients are left to say, I don't really know what to do. And we're not going to change a sedentary health behavior if we don't give them some specific tangible tools and guidance to make that change.
Yeah. I love that. So you're involved with the APHPT. Listeners of the show are familiar with that. It's Academy of Prevention and Health Promotion Therapies, and their podcast, Healthcare Reboot, is a part of the Senior Rehab Project Network. So I know you're on the policy and global health team. So in terms of policy, how far do you think we are from getting paid to have that kind of forward thinking and to really try and work with people maybe before they enter the healthcare system, but really manage kind of their overall health, even if they are in the healthcare system? How far off are we from being valued and actually paid for those services?
To give my realistic opinion, I think we're still a ways off. Mm-hmm. I think the value discussion is a big part of helping us get closer to the table for these for policy to change and for payment to follow suit. Mm-hmm. I think that the changes may need to come more from the ground up level and more from the organizational level, not from the government top down. Mm-hmm. I think we need to partner with our ACOs and have the ACO's ear, accountable care organizations' ear, because their mandate from the Obamacare, the Affordable Care Act, their mandate is prevention. And that prevention has to deal with population health. So if their mandate is prevention and prevention of health disease, chronic disease management type of things, one of the areas that they typically look to therapy for is fall prevention. Patient has an issue. Let's put in physical therapy. And it's always seen as after they've had a fall. it's really never seen as let's prevent the first fall from happening. It's always a sequela of something that we now go back, now we go in.
Yeah.
And so I think by partnering with the ACOs, so I've had conversations with Mike Eisenhart, and we've talked about biomarkers and how we can show value and define our outcomes in measures that are before the fall happens or before the person gets down to that frailty state. Because once they're frail, we have objective measures. But what do we do when they're healthy or following that trajectory towards being unhealthy or towards impairment, and yet they haven't had the fall or they haven't had their diabetes yet? So, we talked about the fact that physical therapy, or I want to say more specifically, proper physical activity and exercise reduces cholesterol levels. Proper physical activity reduces depression. Proper physical activity helps to reduce the risk of diabetes, improves obesity, reduces the risk of metabolic syndrome, geriatric syndrome. So there's so many benefits to exercise. And I've been quoting a lot of times, and I don't know where I heard it from originally several years ago, but I've been quoting that if exercise was a medication, it would be the most prescribed drug. And it really has the least amount of side effects, other than muscle weakness here or there and maybe some fatigue. If you do the wrong exercises, you could have a musculoskeletal injury, of course, but the risks of medications are much greater than the risk of exercise or a physical activity.
Yeah.
And so Mike and I were talking about biomarkers, and if we do the right exercises and we get the patient on aerobic program and resistance training, then we can do things such as hand grip strength. But before they get to that frailty level, we can do things as gait speed, which are measures that people are comfortable with and familiar with, but really before they get to that level of dysfunction. We can do blood work and see if that blood work has changed. Before we add that statin medication, why not try a trial of exercise and see if we can reduce their bad cholesterol levels and their triglyceride levels with a bout of exercise for 4 weeks, with maybe a supplement such as fatty acid, rather than move right to a statin, which we know causes myopathy and has other major side effects. So that's what we were discussing. And with the ACO as the mandate for prevention, I just think that they're really unaware of the value that therapy has in helping them manage their chronic disease patients. And I think for a number of patients that are in these ACOs, there's an overwhelming majority that are not ill. But if we can keep them on a health trajectory of activity, we may help them prevent the sequela that happen from sedentary life and from inactivity. And if we're doing that, then we meet that triple aim of improving the health of the population. And we improve their patient experience because they'll have less interactions with us because they won't need us quite as much. And hopefully, that'll also reduce the expenses or the cost per capita for the care. And that's the triple aim. So I see as valuable in there. And I don't see that physicians, and I'm not looking to put them under the bus at all. That's not my motive here. But I don't see that physicians or even let's just say the rest of the healthcare team and administrators and organizational leaders understand that the true value that we add in helping to improve population. And that's really what I've been tweeting on Twitter is sharing all these articles. And even the CDC has information pages about becoming more physically active. These ChooseMyPlate.gov, the food websites that the agricultural agency and the other federal agencies have. They have super trackers and different mechanisms where they highlight the need to be physically active. Even the Surgeon General has recommendations for physical activity, and because there's evidence to show, in randomized trials, that physical activity improves health. And it's just astounding to me that physical therapists in particular, that are the movement specialists that prescribe exercises and physical activity, are not at that table. And it's a matter of go find the DVD and just do it on your own.
Yeah.
And that's where I see a ground level approach makes a difference at either an individual level, maybe go to some, and this is what we've been doing, piecemeal, going to community centers, doing these health fairs and screens which of course are all voluntary, is one way to improve our footprint. But I think that on a meso level or organizational level, we need to look to partner with these ACOs and show them the data. And coming back to dirty data, it's important that what we have is clean. If you take 4 patients and you just decide that you're going to do a measure on these 4 patients, one of which is independent, working full-time, one of which is retired and sedentary, one of which is working part-time in a chair, in a more sedentary lifestyle, and you give them all the same test measures, they're all going to score differently, most likely, because of their prior level of functioning and their current activity level. Yeah. And so when we compare the data, is it risk stratified? Is that data comparing apples to apples? And if it's not properly used, then what happens is it just doesn't show that there's a value. Yeah. And, there's an article that came out recently that's been on Twitter that the practice committee of the home health section is actually writing a letter looking at the article where it compares outpatient and home therapy. And we looked at the conclusions, and a lot of these conclusions have bias, and we have questions about the data that they're sharing. And more to come on that as the committee and then with the section.
Yeah, I'll put a link to that article in the show notes. I did come across that and found it rather disturbing in terms of the claims that were made. I do want to mention, let me write this down. You were talking about Mike Eisenhart and just kind of the whole population health discussion. For listeners, if you haven't heard my interview with Mike, look in the show notes. There's a link to that, and check out aphpt.org. But so one thing that you mentioned, Kenny, that I really liked was proper physical activity. And this is where I feel like we as PTs are in a very, very unique position, because we do have the skill set to prescribe exercise across the lifespan to a point that it is going to be proper, that it's going to be adequate for adaptation and to get results. Because it's one thing to just tell someone to go walk, which is not bad. I do see the value in that, but we have the ability to manipulate and change variables to make that walking as effective as possible, or whatever exercise it is. But I do realize that there are a lot of PTs out in the field that may not feel comfortable prescribing exercise to an adequate dosing in terms of intensity or volume. And I do want to bring up, the course I know you've been through, the Certified Exercise Experts for Aging Adults that's put on by the Academy of Geriatric PT. I think if you're questioning your ability to dose and prescribe exercise, this course may be something to look into. What was your experience with that certification? Do you feel like it helped you be able to kind of step into the role of prescribing proper physical activity?
I'm actually one of the faculty. I'm actually faculty for the CEEAA.
Oh, well, you're so biased then.
So I am biased. I have to admit there's a bias for me for that program. To give a small background, my background as far as that program and as far as objective testing, I was asked by Tanya Miller, who in 2008, 2009, the articles were published, but I believe it was 2008. I was asked by Tanya Miller, who was then the publication committee chair and editor of the quarterly report, Home Health Section publication. She asked me to write a series of articles. And because I had prompted her initially, I had some ideas of writing an article for that publication on clinical pearls, where I was hoping to have a monthly article on assessment tools or intervention tools. And so she came back and said, that's a good idea, but we would like you to do a 4-part series, and would you want to do it on objective tests? And that's what I was thinking with the clinical pearl, was going over an objective test each month or an intervention each month. But we ended up coming back to having a 4-part article series, which was a CEU. And so I went over 4 tests, objective tests. I went over the 1-leg stance test. I went over gait speed. I went over 30-second chair stand test. I went over 2-minute step test. And I purposely picked one measure from each of the different impairment categories. So I had a balance measure, I had a falls prevention measure, I had a gait measure, I had a strength measure, I had an aerobic capacity measure. And a couple of the measures overlap falls and balance, and falls or gait also. So I put those articles out together back in 2009, and that really is what got me moving towards teaching objective test measures, which I did with Dee Cornetti for a few years. And we actually did a pre-conference in Chicago on objective test measures. And I'm not sure what year that was, 2012, I'm not sure. But we've been teaching, Dee's been teaching objective measures. I've been teaching objective measures, since that point. And then in 2012, I took the CEEAA courses myself. And the first course is all on objective test measures. And when I sat in the course, a lot of that wasn't new material to me because I'm very comfortable and know a lot of the measures in my research. But I felt that the course was done so well that, I ended up stopping teaching objective test measures on a bigger scale and would recommend people to take that course series, because the course series also includes the second and third courses go over how to actually dose the exercises effectively and appropriately and provide interventions for the general population of older adults. But then the third course goes over specific I don't even want to say special, but specific populations of older adults that have, diagnoses specific conditions, health conditions, such as how do you treat a patient with Parkinson's, or how do you treat a patient with osteoporosis, or if they have had cancer or transplant surgery. So it goes over the different specific populations. And so I've really stopped teaching objective tests as much as, I have, because they do such a good job of teaching and providing a lot of opportunity to actually practice the tests. And so that's why I stopped teaching it. As far as the other part of the interventions, Justin, you're spot on. If you're a clinician and you are documenting you're doing aerobic training or you're doing endurance training, and the patient has an impairment, so they can't function in their home, they get short of breath walking 10 feet, well, that type of endurance training is covered under Medicare. Medicare does not cover endurance training or conditioning when there's no functional or physical impairments in play. But if I have a patient that is homebound, in home health, they have to be homebound, and they have a physical impairment, an endurance component limitation, they're not able to ambulate long distances, they can't get to the car without having to stop and rest, then they have shortness of breath issues. The question is, how do I get them improve their endurance? Well, many clinicians document that they work on aerobic training. I challenge that documentation very easily by saying, at what level of intensity are you dosing their exercise? Are they working at a certain MET level, or are they working at a certain exertion level that is forcing the heart and lungs to adapt to a challenge of activity? And so if you look at overload principle, if you look at physical stress theory, if I do not challenge my patients at a level sufficient to have the body have to do something, the body will not do anything. And I'm at best at that point maintaining the patient. So a good example is to have a patient that is able to walk 50 feet, and I go into the home and I say, you know what, we need to have you walk more distance. So I say, I want you to walk every hour 50 feet. And by the total of the day, I may get more steps in for the day. Is that specifically aerobic training? And my argument is not if the heart and lungs are not forced to adapt. So the person needs to work to a small level of a fatigue level, and they need to work at an intensity that creates either a heart rate response or a pulmonary response, or both. And if they're on a beta blocker, then we know heart rate will be blunted, but that's something that we need to use an RPE scale for. Right. And if I'm saying things like 30 to 60% of 1RM, or I'm saying RPE scale, and I'm saying these things about intensity and they're not resonating with the audience, then really you need to look back at the literature. And I recommend that CEEAA course is one mechanism of becoming up to date with your skills, and then document your exercising your patient at a 30 to 60% of 1RM level, or 70 to 80% of 1RM level, or 80% of VO2 max. or however we want to document, we need to challenge our patients. That's probably our biggest detriment to our profession, is we underdose our patients.
Let's go ahead and transition. I want to be respectful of your time, but I'm just going to ask you some quick questions. Your answers do not have to be quick by any means, but I'm curious.
Okay.
What would you tell your 25-year-old self? And if you could tell us where you were and what you were doing at that time, just to give us some context.
If I could talk to myself at 25,
Yeah.
I love what I do where I am in my career. I absolutely love our profession. If I could tell myself at 25 to do something different, I would tell myself to learn more about the business end of therapy and about advocacy end of our business, because it is a business. Unfortunately, there's payment involved, and I think too many clinicians do not know the business end of practice, of therapy practice. And I think that's a detriment, because I think many clinicians are taken advantage of. And I don't think it's a majority. I think it's a minority, but I think it's a significant minority that it affects our industry as a whole. So people need to know how the payment is generated for wherever they work. They need to know about the 8-minute rule, if it's billing codes and CPT codes and G codes. And, I interviewed someone not too long ago for a position and in home health. And I had asked them, what objective test measures do you utilize in outpatient? And they told me, well, we don't use any. And I said, yeah, but you have the mandatory reporting, and you have the G codes that you need to use and to define the functional limitations of your patient. And he says, I don't know what you're talking about. And so I said, well, I think you need to go back to chapter 15 of the Medicare policy manual if you're accepting Medicare money, and somebody's billing behind your back the codes and putting in functional limitations that you're not aware of. And so you need to look at what your regulations are. And that would probably be the biggest recommendation I have for any new clinician, is don't take anybody's word for it, even my word. I can talk about spinning out regulations, but make sure that you go back to the source document. Go back to the chapter 7, 8, 15, whatever chapter it is in the policy manual. Go back to the OASIS Q&As where the Medicare defines and answers questions. And don't just take it from someone's word what is or isn't the regulation, because a lot of areas of gray and misinterpretation are abound, like the myth of the 150-foot rule. That's a myth. There's a myth about therapy lupa is another myth. So there are many myths abound, and unfortunately, they rear their ugly heads, and they're not true. But people follow practice thinking they are.
Yeah. I'm definitely guilty of that. And I'm just now realizing just kind of the intricacies of the setting I'm in. So yeah, I love that advice. What's been some of your most helpful content online and in person in terms of different, courses that you've taken?
Well, I went back for my DPT a few years ago, and the program that I went to was a live program. I know there are hybrid programs. I know there are online programs, and I think that anybody that is looking to take CEU courses, there are vetting processes in place, like the home health section. If someone is looking to join the home health arena, I highly recommend joining the home health section, because there's many resources. There's podcasts that are free. There are also webinars and audio conferences available. And start with whatever you're working in your professional association. If it's the APTA, if it's the AOTA, if it's ASHA, start with your professional association and go through their documents, like the Guide to PT Practice. So start with the standards that are already existing. And if you go to a continuing ed course and you say, you know what, that looks like a nice topic, look at the references that they're citing. They should have their references there. They should be peer-reviewed references. If they're not willing to share the references and it's more opinion, those are the types of courses where I try to shy away from those, because you want to use evidence-based information in your practice. As far as you had mentioned MedBridge. MedBridge does a wonderful job with their courses. They put a lot of time and effort and a lot of resources in developing online courses that are very interactive. The animations are, I mean, professional, top notch.
Yeah.
It takes weeks to months for them to finalize a course. And so when the person takes a course, it's not just a voiceover PowerPoint presentation.
Right.
And so, what you get what you pay for. They are a little bit more money for their membership, but you get top notch quality from the leaders in the industry.
Sure.
I also do courses for and I don't want to make this a solicitation. If you Google me, you can find where else I do courses. I don't want to mention everybody by name, but there are different ways to get CEUs for less money. Again, look at the speaker that is providing the information, and then do a quick Google search on that speaker and see that they've been vetted, see that they have credentials. So that, and then if you take that course, make sure that the references are there to support the statements that they're making.
Yeah. Yeah. And I'll solicit for you. So
Okay.
MedBridge is an awesome platform. But listeners to the show, if you do not have MedBridge, or if you have it and you want to review, you can get a year subscription for $200 if you use the promo code Senior Rehab Project. No spaces, all lowercase. I'll put a link to that in the show notes. So, several guests on this podcast. We mentioned Dee Cornetti, Cindy Kraft, Christina Novak is going to have a course. Ken Miller, several other people have courses that are geared towards people like you and me. So $200 for a year subscription. And then also, I believe you've done a course with Carol Lewis's group, the Great Seminars, books, and education. So I'll put a link to that as well. So just look in the show notes, people, for where you can find some of Ken's content, but also other helpful content for what we do. So next question, who is someone in our PT world that we should know more about?
Ooh, that could be a lightning rod of a question. If I don't, it's like winning the Academy Awards. If you don't mention the right people, you're going to hear about it later. So that's a lightning rod of a question. I will answer the question.
Mm-hmm.
Before I answer that question, just to tag on to the last item, if anybody that's listening in has any questions on pharmacology, that's the topic that I actually have put together a 2-day course for Great Seminars. Mm-hmm. And the topic is clinical implications of pharmacology for therapists working with the older adult. That's a mouthful of a title. Yeah. But that's really what it is. It's pharmacology that is important to you as a therapist treating patients. It doesn't go over all the chemical formulas. It doesn't go over bromination and all these other things we learned in chemistry. It goes over, well, what does it mean for me as a clinician if they're taking a Xanax? What does that mean? And so it's really more of a practical course on pharmacology from a therapist perspective. So that I just wanted to add that tag since you brought up Great Seminars. Mm-hmm. As far as the question you asked, who would I want people to watch? Really, what I need to say, and it might sound like a political answer, I don't mean it to be, is I work with wonderful people in the practice committee and the executive committee and the board of directors. Really, I would go to the section website, look at the table of organization, and really any of the members that are part of the home health section's leadership are the names that I would follow. We have leaders that are with the research committee. Tracy Collins out of Pennsylvania and actually she's flying out to MedBridge to record a course either next week or within the next couple of weeks. She'll be going out to Seattle. Nice. But really follow the leadership in the home health section, because many of the leaders have similar passions that I think you and I have, Dustin, and they have they really sought out. They will seek out for themselves to be at the top of the practice to try to make sure that what we're providing is the best possible care. And I think that's a common vision that we all share. Yeah. The members of my practice of our practice committee, some of them have presented at CSM, and I try to encourage them to present. We'll actually be presenting, hopefully, if it's accepted, a program next year on the new graduate mentorship program that we put together last year to try to promote CHAs and other, home health agencies to hire new grads, put in place a proper mentorship program, and hire actually new grads to try to promote more therapists working in home health. So we are looking to do that. Really, to answer your question, though, I think look at the leadership of the section, and not only even the home health section, but a lot of the leadership of the Academy for Geriatric Physical Therapy, which I'm a member of that academy as well. They do a lot of education, and they're very involved. So just look at the two organizations' websites, and you'll see a whole bunch of names. And if anybody needs anything specific, reach out to Dustin or even to myself, and I can help you with your needs that you may have.
Yeah, definitely. All right, last question, my favorite. So let's say we're at CSM, you're in a big old room, you have every geriatric rehab clinician paying attention to you for about a minute. What would you want them to know?
Well, what I'd want them to know is that even when they're alone, there's always somebody watching, and that watching is through the data that they're gathering, the documentation that they're creating, and the patient that's on the other end of the receiving end of the care provided. So make every second that you're with that patient and in that computer count to reflect the value and the true care and compassion that you have for your patients, so that in the end, we get paid for what we do. Because all of this discussion about population health, triple aim, and all these things are wonderful to talk about. But if we don't get a seat at the table and we don't show our value in relation to the patients seeing that, you know what, I got to have therapy because Dustin was great, and he, you know what, I'm going to pay out of pocket if I need to, because he's really helping me stay out of the hospital. You know, I would love to have a patient say that instead of what I see a lot of the time of, you know what, if it's not covered, don't come back. To me, that's just a sad commentary on our profession, and we need to demonstrate value in everything we do.
Preach it. I'm very glad that you mentioned that, as I have to go see a patient in about 30 minutes. So that will be fresh on my mind. So Ken Miller, thank you for your time. I mean, you've got quite the career so far, and it seems like you're just getting started, just with everything that you're involved in and just really moving the needle forward. So thank you. I'll thank you on behalf of the listeners as well, because you've definitely made an impact, for sure in the home health arena that I think we've all reaped the benefits of in some way, shape, or form. So if people want to, connect with you, pick your brain a little bit, where can they find you on the internet?
I think the easiest way to get a hold of me is through Twitter. My Twitter handle is the @ KENMPT, Ken, my first name, M for my last name, PT is my profession. So Ken MPT, at Ken MPT is how to find me on Twitter. Okay. And then we could message in individual message if we need to from there.
Okay. All right, listeners, you got it. At Ken MPT. All the links that we mentioned will be in the show notes. Ken, thank you for your time.
All right, Dustin, thank you so much, and have a great day.
Hit me. Thank you for listening to the Senior Rehab Podcast. I appreciate your time, and if you enjoyed this episode, do me one favor. Share it with one other person that would benefit. Thank you. If you want to see the show notes or find more episodes, just go to seniorrehabproject.com. And until next time, my friends, do not forget to stay funky. The Senior Rehab Podcast is sponsored by Great Seminars and Books. If you need high-quality geriatric con ed that's worth your time and money, check out Great. Owned by the living legend Carol Lewis, Great offers courses and products created by recognized leaders in geriatrics. Learn the most effective techniques for diagnosing and treating your patients. Just go to seniorrehabproject.com/great and get $25 off by using the code SRP25. The show is also sponsored by you, the listener. Go to seniorrehabproject.com/join to find out how you can help steer the direction of this movement and join our monthly meetup. Once again, that is seniorrehabproject.com/join.